Good evening and welcome to the premiere show of a new season of Doctors on Call. This is our 34th year. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School here in Duluth. Tonight our topics are heart problems and high blood pressure. So what would you like to know about the diagnosis, treatment, and prevention of heart attacks, heart disease, heart failure, high blood pressure? Call with your questions 218-788-2844 or toll-free 877-307-8762. I'm pleased to welcome this evening's panelists, Dr. Ramin Artang, a cardiologist with Essentia Health, St. Mary's Heart and Vascular Center, Dr. Scott Mikesell, a cardiologist with St. Luke's Cardiology Associates, and Dr. Jacob Prunuske, family medicine physician with Lake Superior Community Health Center in Superior and a faculty member at the Medical School in Duluth. Tonight we have medical students answering the phones. They are Emily Davis from Virginia, Minnesota, Tyler Kunst from Belle Plaine, and Cale Seibert from Deerwood, Minnesota. And now on to tonight's program about heart problems and blood pressure. This is a very large topic, and Jake, could you just talk a little bit about heart disease and kind of help us focus in?
Mm-hmm. Well, heart disease is really important because heart disease as a general category is the leading cause of death in the United States, and it impacts directly lots of Americans and certainly all of our family members and friends. When I think of heart disease, the heart functions in our body to pump blood around, and so anything that disrupts that process would generally fall into the categories of heart disease.
Dr. Artang, we talked earlier, there's a few different definitions I'd like to bring out. Can you talk a little bit about angina or angina?
Sure. Angina is related to coronary artery disease. So as you understand, the heart is built of muscle, valves, and vessels. So once the vessels are diseased, they start to block down and they get narrower and narrower. I compare the angina to an engine that runs for the most okay, but once you go beyond a certain RPM, it starts to fail. And stable angina is a condition where you actually are doing fine, but as soon as you go beyond moderate degree of exertion, you start to have chest pain symptoms, and once you go back to rest, you will be okay again. That's, as it said, it's a stable condition, and it is not an emergency, but something that may need to be attended to. As compared to an unstable angina, that is more, as it said, more unstable, and it requires possible hospitalization and further attention.
Well, Dr. Mikesell, you could probably carry us to that next step then with, what is a heart attack?
Carrying on his comments, actually a heart attack is simplistically, you've outstripped the heart's ability to receive oxygen. And so there's tissue damage to the heart because during some sort of activity level, whether walking or even just breathing, in this case of unstable angina on occasion, the tissue of the heart actually is so deprived of oxygen that there's damage that occurs. There's two types of simplistically heart attacks. There's an acute version where one of the arteries of the heart just 100% blocks with a thrombus or a blood clot that forms on top of cholesterol. And then there's a version that's similar that is a progression of stable angina where there's such a small amount of blood getting through the artery because of the narrowing of this artery that it gets so deprived that you end up with small to medium-sized heart attacks as a consequence.
I want to talk a little bit, probably stay with heart attack just for a few minutes. I'd also like to get into the rhythms a little bit, Dr. Artang, in a little bit, because I know that you do a lot of work with blood thinners and so on.
Yes.
Dr. Prunuske, so you're sitting in your clinic over in Superior, and someone comes in. What are the worrisome things that should make me come to your clinic regarding my heart?
Yeah, well, you know, a lot of people think and worry about heart attack, and I think one of the things I think about is that it's very important to distinguish between how heart attack presents in men and how heart attack presents in women. In men, heart attack presents like we see on TV. People have crushing substernal chest pain. They may feel a sense of impending doom. They may have a sense that they can't get enough oxygen. They may feel a heaviness on their chest. Women often present very differently, and for years physicians would miss heart attacks in women because rather than those symptoms, women would present with sort of a vague unease. They might have some nausea or indigestion, maybe shortness of breath, but their symptoms are very different than men present. It's important if someone has symptoms of a heart attack that they seek help right away. And actually, I'd hope that they not come into my clinic, but rather go into the ER or call 911, although it does happen from time to time, and we do send people from clinic to the emergency room.
So the discussion really is to encourage our patients, our people that we're talking to tonight, that something like this is emergency room, not doctor's office.
Yeah, and to carry it forward, actually, if you look at the data, even for the state of Minnesota, when it comes to heart attacks, the acute heart attack, the big heart attack that we take to the heart lab right away and try to get that artery open as quick as possible, roughly 45 to 50% of people drive themselves either to a clinic or to the hospital themselves. That is a potentially deadly scenario. If you look at the statistics on this, people that do that are far more likely to die of their heart attack or have a worse outcome as a consequence. So if there's anything that anybody takes from this show is if you feel like you're having a heart attack, dial 911, because our EMTs, our paramedics are exceedingly experienced and well-trained in how to deal with the initial phases of a heart attack. The number one thing that a patient can do for themselves is just dial on 911 themselves or someone or one of their family members.
Dr. Artang, Dr. Mikesell brings up a good point about our EMTs and paramedics. We've moved really a lot of the treatment of early heart disease right out into the field, haven't we? You know, I've had patients bypass Moose Lake and come to Duluth and have had heart attacks. So we want them out.
One of the more modern way of dealing with this is that the EMT personnel is already able to do an EKG out in the field, and we already know within minutes after the arrival whether this is acute emergency that needs to be flown or driven to the cath lab as soon as possible, or they can take their time and do more before transporting the patient. So that is a huge deal in treating with acute heart attack, is knowing what's going on right on within the first few minutes of meeting the patient, and even initiating some of the medical management that they can start with, such as platelet inhibitors.
So there's a time element here right away.
Yes.
So how much time does a patient have? You know, I always remember 90 minutes from onset to being in your lab.
Sure. It's an excellent question, and actually it depends on where you're coming from. Generally, the American Heart Association recommends we have what the fancy term is door-to-balloon time. So the minute that somebody rolls into some emergency department, generally ours, whether it be Essentia or St. Luke's here in town, the benchmark is to have that artery open in 90 minutes from the patient presenting to the emergency room. Let's say they presented to Moose Lake, though. It's a little bit longer because of the transport time, so we're expected to have that artery open within 120 minutes, which during this season is actually, the systems actually are built so well that that's not as challenging as it used to be. However, come wintertime, you know, when we're trying to travel, get somebody from Hibbing or wherever, or Ashland, I-Falls, yeah, it's a big challenge, and you know that's where our helicopter transport comes in. The old saying is time is muscle. That's been the same way for 30, 40, 50 years. It's just a matter of getting it open. Not unlike dealing with stroke. It's a very similar phenomenon. There's a finite amount of time that the heart is able to tolerate having no blood flow. It's an excellent point about the medications, because the sooner the medications get in, the more likely the blood clot may not be present when we get into the lab. We still have to deal with the obstruction or the cholesterol buildup, but the artery may open unto itself. And so the sooner, again, going back to 911, if somebody can call, we can administer this stuff, we can get them through, the better their artery is going to do in the end, and thus globally the better the heart and the patient's going to do.
So the systems we have to treat people are outstanding. But I have to add that one of the most important things that people can do is actually not put themselves here in the first place. Yeah. And there's a lot people can do in terms of just leading a healthy life to reduce their chances of having a heart attack somewhere down the road. So making sure people maintain a good level of physical activity, a healthy diet. For many people that involves maybe taking an aspirin a day or a cholesterol medication. But I think looking at ways to prevent heart disease for many, many people is really, really important. For people who have diabetes, controlling their diabetes. For people who smoke, obviously quitting smoking is a very important part to reduce their likelihood of ending up needing kind of these more invasive services. I mean, they do a remarkable job of saving lives. But I think, I'd be remiss if I didn't mention that there's a lot of opportunity for prevention too.
Absolutely.
One of the one of the questions is what is the most important thing you can do to prevent heart attacks? And Dr. Artang, wouldn't that be to come in and see someone like you or Dr. Prunuske or someone, one of us?
Well, if everybody listened to Dr. Prunuske, we would be out of job. So that is an extremely important point, that prevention is absolutely important. And it starts from kindergarten. It starts from early age, healthy diet habits from early on. So not that the kids can eat all the sweets they want, and once they become 18 or 20 or 25, now it's the end of that. That's not true. I think everybody should enjoy life and eat something that they like to do, but do it in moderation. And that starts from early childhood. Healthy diet habits, healthy activity, stay active all throughout your life in all age groups. And that is incredibly important. And once you reach a certain age level, such as in your 30s, it used to be in the 40s, but my recommendation is should be in the 30s, that you start checking your cholesterol, or even earlier in the high school. This is something we don't do, but something we should start doing, because if the kids' blood cholesterol is already high, if the blood pressure is already high in high school, they are in trouble. They will have their first heart attacks in their 30s, as compared to previous generation who will have their heart attack in their 50s and the 60s. And this is something that you may be seeing in your cath lab, that you're seeing younger and younger patients who are coming with heart disease that we just 10, 15 years ago, they used to be 20 years older.
And in our offices, we're seeing younger and younger people and younger diabetics.
Yeah, absolutely. It's impressive. Things that we used to consider adult diseases or diseases of old age, we're now seeing at younger and younger age groups. And I think, in large part, it's something we have brought upon ourselves as a society as we become less active and less physically fit, sort of less in tune with our health in general.
The irony is we have better tools to deal with this, preventively.
Yep.
And so, we can look at say a lipid profile and gauge risk much better based on lipid profile than 10, 20 years ago, just looking at the total cholesterol, something like that. I mean, there is sophistication in our abilities to prevent these diseases, and they are preventable, and he's exactly right. We'd be out of jobs. But
and the idea is not for everybody to be vegan or to be a workout master. The idea actually quite simple, just less fat, less carbohydrate, more physical activity, and that is as simple as 30 minutes of walking every other day.
Yeah, little things make a big difference. If you golf, walk rather than drive the car.
Exactly.
Park. When you go to the grocery store, park in the back of the parking lot rather than right by the store. Take the steps, a flight instead of an elevator. And if you start that as a kid and just maintain that lifestyle, it can make a big difference.
Absolutely.
There's other things. There's other ramifications of heart disease. We're keeping people alive, and we're doing a better job of doing that. One of the things we see maybe more is atrial fibrillation, which is an irregular heart rate. And I want to go there just a little bit because of your expertise with the blood thinners and your expertise with some of the newer blood thinners. I'm used to using warfarin and Coumadin or whatever name you want. There's all kinds of names have been stuck on it. But we have new ones available now. Do you want to talk about that just a little bit?
Sure. There's a it's very interesting discussion. Speaking of warfarin and Coumadin, same drug by the way, has been around since 1930s. And initially developed at University of Wisconsin, by the way, for our Wisconsin audience.
Wisconsin Alumni Research Foundation.
Exactly.
That's
correct.
Exactly. And we know a lot about it because we have been treating patients with it for 50 years. So everything we need to know about, we do. The problem are a few. One is drug interaction with other drugs, and one is interaction with foods. And many of these patients are recommended not to eat some type of vegetables or the other. And the other one, last one is the frequent need for monitoring. Now, the purpose of the new blood thinners are to get rid of some of these things, including the frequent monitoring and less drug interaction, less food interaction. So that's the advantage of the new blood thinners.
Great, and they're out, and we're seeing them in our offices. Congestive heart failure pops up a little bit in the questions. Jake, do you want to take a lead on that and talk about it just briefly?
Yeah, congestive heart failure is a relatively common condition. Sometimes happens as a result of a heart attack, but also sometimes happens as a result of viral infections or other things which cause damage to the heart muscle. And what congestive heart failure, it's actually a condition that combines the dysfunction of the heart with the lungs. And if the heart isn't able to pump effectively, the pressure behind the heart builds up, and that pressure causes fluids to leak out of our blood vessels into our lungs themselves or into the fluid spaces in our body. So people can get difficulty breathing, sometimes can get swelling of the legs as a result of heart failure. If it gets severe enough, it can be very debilitating and really limit a person's ability to engage in life activities.
Other comments, gentlemen?
Any of these conditions can cause heart failure. It's really a catch bag of lots of different things, and there's always a reason for it. Sometimes, most of the time, we're able to find it. Sometimes we cannot. Atrial fibrillation is an interesting entity in that it's not only a sign of heart disease or blockage, but also can be a cause of heart failure. And so these are very important conditions, to manage and deal with in long term, because it long term can actually, I should say, the heart has an amazing ability to heal itself over time. And so being able to treat these conditions with appropriate medical regimen actually can return somebody very close to normal, and happens regularly.
Dr. Artang, I goofed it just a little bit because one of the questions is what is atrial fibrillation and how does it happen? So do you want to just clean that up for us?
Again, these are amazing questions, and they are not so easy to answer. We try to figure out what is atrial fibrillation. I mean, we know what it is, but we don't know why we get it. The upper chamber of the left side of the heart is called the left atrium, and that chamber is like a balloon. It's not as muscle filled as the lower chamber. And for a person with some kind of heart condition, such as high blood pressure or coronary artery disease or valvular disease, that the pressure in that chamber with time gets higher and higher. That chamber gets larger and larger like a balloon. And once the anatomy of that chamber is distorted, it starts to give extra signals, extra electrical activity. And once it turns out into a storm of electrical activity, that's where the atrial fibrillation is. What the patient will feel is that the heart is racing twice or 3 times faster than it's supposed to. So these heart rates are in the 150s to 190s, and they will feel uncomfortable about it. So that's what atrial fibrillation is. The major risk of atrial fibrillation, which is a easily treatable condition, is stroke. So how we treat atrial fibrillation is by slowing down the heart rate and putting the patient on the blood thinner. So in that way, the palpitation symptoms are resolved and the risk of stroke is relatively close to normalized.
Are there some other procedures you guys use besides just the medicines, interventional things for atrial fib?
Not myself, but my colleagues, electrophysiologists, you can get as aggressive as doing an ablation procedure for atrial fibrillation, which actually over the years has become more and more successful. The medications are very similar. You continue on the blood thinners when you're going through this. There are more aggressive medications that try to control the rhythm, actually try to keep you into what's called normal sinus rhythm. Also associated with taking the anticoagulants as well. And then we can actually, on a regular basis, I'm sure he does this as well, we try to shock people back into normal rhythm and try to maintain that normal rhythm before we get to the ablation part. But there's a whole bunch of things that we can do besides just, controlling the rate and the blood thinners.
So, Dr. Prunuske, the question comes up, blood thinners, what are the risks? We've talked about the good part.
Sure. So, I mean, blood thinners, it's a kind of a misnomer. I mean, it doesn't actually make our blood thinner. Normally when we cut ourselves, we have systems in place to stop that bleeding. And what the blood thinners do is make those systems a little less effective, so our blood doesn't clot up or doesn't coagulate as well as it normally would. In the context of atrial fibrillation, that's important because if the heart is kind of beating irregularly, you can have places where the blood pools and it becomes likely to form a little clot. If that clot breaks loose, that's what can cause a stroke. 1 to 3% of people with atrial fibrillation untreated in a year will have something like that happen. So what the blood thinners do is make that clot formation less likely. And we use them in the context of atrial fibrillation to try to prevent people from developing a stroke. The blood thinners don't treat the atrial fibrillation, but they prevent complications from it, which could be devastating for people who have atrial fibrillation.
I have a question from Hibbing, and
Sorry, I'm going to follow up.
you got another?
Well,
Okay,
no,
good.
I'm just going to say that the complication of using blood thinners then is because our blood doesn't coagulate, doesn't stop bleeding as easily. People on blood thinners are at some risk for bleeding in the stomach, so they can get bleeding in their stool. They can have bleeding in their stomach. Sometimes in more serious conditions, they could even have bleeding in the brain and suffer a stroke from that. But fortunately, for most people, the complications, that risk of bleeding is far less than the benefit they gain from being on the blood thinners.
I have a question from Hibbing, and it just reminds me that this show in the past was handled by a good friend of many of us, Dr. Ben Owens. What would you recommend first for treating cholesterol? Diet and exercise, or would you go to medications?
It depends a little bit on the person and
Yeah.
what their risk factors are. It's not a one-size-fits-all answer. So how old are they? Do they smoke? Do they have high blood pressure? Do they have diabetes? Are they male or female? Are they white or African American or some other ethnicity? And these things all play a role. So I used to think about treating cholesterol, and we had number targets, and we tried to get people below those targets. And in the last several years, I've really changed. And I don't think about treating cholesterol anymore. I think about managing cardiovascular risk. And so I use that cholesterol along with many other things to look at an individual patient, see what their heart risk is. And if their heart risk is great enough, and I use, if they have a risk of having a heart attack about 7.5% in the next decade or so, that's high enough a number for me that I will put them on medications to help manage cholesterol.
Yeah, and it depends on family history. Certainly family history plays a role, and actually family history can be as predictable and as morbid as some cancers when it comes to these sorts of issues. Absolute levels of LDL and HDL and the ratios between the two, so it's become a little bit more complicated. So again, I agree completely with Jacob. And if you would get to us,
We'll put you on phone.
then we're
That's where you start.
and quite frankly, it's over. The preventive part, we want to prevent future events, but you're with us, and
It's a fundamental difference between a person who already had a heart attack or established coronary artery disease or had a stroke as compared to a person who haven't had any of those and is here for prevention. Because those people who have the disease, they absolutely, regardless of their number, needs to be on the medicine. We know that the medicine helps them. It will make them come to the hospital less, have less stroke and less heart attacks, no doubt about it. But for people who are doing this for prevention, again, as my colleagues mentioned here, it's dependent on many different things, but fortunately, the National Institute of Health has a calculator that includes these risk factors that you place into this calculator and gives you a number. And that number is a very good guide to whether this patient needs to be on a medicine or not. And often, ladies or young gentlemen with high numbers, I do not put on medication because they don't need it, and it's not going to change their risk.
And I think on most of our EMRs or electronic records, the little calculator is probably handy. Whoever wants this one, kind of running out of time. What are the causes of aortic aneurysm, and is there a hereditary component to it?
The answer is yes.
many causes: genetics, high blood pressure, smoking, the typical risk factors, valvular heart disease.
Is smoking good for us?
No.
Okay.
I mean, not at all.
No, never.
Yeah.
We just got to get it out there.
Yeah.
If you're smoking or using
It's-
tobacco, quit.
It's easily it's the most modifiable risk factor that we have.
But you can't change who your
Yeah.
parents are.
Right.
You can't change the fact that you're getting older. Sometimes even changing activity or weight can be really difficult. But quitting smoking, as hard as it is definitely something you should talk to your doctor about. And
Yeah.
there are many options to help people quit.
Single most bang for the buck that you can get from a prevention point of view.
Exactly.
How long are stints good for?
If you get a drug-eluting stent, our current generation of stents would suggest potentially forever compared to the earlier generations. Our generations are phenomenal now. We do not see the returns that we used to. There's another type of stent, bare metal stent. They have a little bit more surveillance and follow-up that is necessary.
If I may add, it really depends on how the patient take care of themselves. So
Yeah.
if they take good care of themselves and modify the risks, it's going to last forever or almost forever. But if they don't, it's not going to last their shelf life.
Yeah.
Alcohol, is it helpful in atherosclerosis? Quick answer, yes, no,
Unknown.
unknown?
You don't need to drink a glass of wine every day to be healthy. If you like it, with moderation, it's good, but it's not necessarily for the health. It's just for the joy.
Yeah, and unfortunately it gets complicated because you have to figure out what kind of alcohol you're drinking. So everything in moderation.
Exactly.
Gentlemen, great show, a lot of things covered tonight. I thank you very much. Please, I want to thank all three of you, Dr. Artang, Dr. Mikesell, and Dr. Prunuske. Please join Dr. Alan Johns next week for a program on infectious disease and immunizations, when his guests will be Dr. Lisa Prusak, Dr. Paul Sanford, and Dr. Linda Van Etta. Thank you very much for watching, and good night.